In this discussion, we will be talking about your intracranial hemorrhage. Class, when I say intracranial hemorrhage, it is an escape of blood within the cranium. Okay, so I am showing to you a CT scan image because for several times you might be seeing CT scan image already on my slides, and you might be wondering what looks normal and what looks abnormal. Okay, a radiologist will be a good reference person for us to be enlightened on this topic. But as a nurse, I can give you few ideas on how a CT scan would look like. Class, this is a CT scan of your entire brain. Okay, so this is a CT scan, or what we refer to as your cranial CT scan. Okay, oftentimes you might be seeing plates like this, okay, on the images on my slide. And you might be wondering if these plates are already normal or abnormal or what. Okay, so class, as far as I'm concerned, the one that is shown here are normal plates. Okay, all of these are normal. Now, you might be wondering, what do I mean by that? If you would look at this class, there are 32 slices. Okay, CT scan machines here in the locality would have 16 slices, 32 slices, and we even have 64 slices. So class, what you are seeing from these images are different cross-section of your cranium. Okay, so these are not different skulls, these are not different brains. Okay, this is belonging to a single patient, and then class, this patient had undergone a CT scan with 32 slices. Okay, meaning class, once the CT scan is taken, these slices are being cut off by the machine for us to be given a cross-sectional view. Okay, so class, it would like this. Okay, so if this is the skull of your patient, the first cut would be here, the second cut will be here, third, fourth, five, till it will go down to 16 or 32, depending on the capability of the machine. So class, the different images on the previous slide would show you the different views of the brain depending on these layers or depending on this cut. Okay, this is not very important, or this is not, let's say, crucial, or this is not part of your licensing to be a nurse, but knowledge on the imaging studies would help you later on your practice as profession. Now, let's talk about the pathophysiology and manifestations of your intracerebral hemorrhage. Class, the trauma or shearing of the blood vessels may result to intracranial hemorrhage, and then later on would result to hematoma formation. Okay, so class, it may be because of the trauma or maybe the blood vessels which have ruptured. That would result to your intracranial hemorrhage. Once this hemorrhage class is there, once this bleeding is there, it may form hematoma. Now, okay, this hematoma might be able to result to any of these three. 1. Pressure and compression of nearby tissues, hence having the localized damage. 2. There may be tissue ischemia, okay, and death of the tissues resulting from the pressure and compression of nearby tissues. Second, there will be an increase in ICP related to swelling. And then third, you will also have the risk for herniation of the brain. Okay, class, these signs and symptoms would be just like your patient with altered level of consciousness. You would be expecting pupillary changes from this patient who is having intracerebral hemorrhage. Because after all, class, the presence of hemorrhage and hematoma within any cavity there of the brain tissue will still result to an increase in intracranial pressure. Hence, the signs and symptoms are congruent. Now, there are several locations and types of cerebral hematoma. Let's try to tackle them one by one. Okay, so you have your intracranial hemorrhage. Class, in your intracranial hemorrhage, okay, or the classification of your intracranial hemorrhage with hematoma formation are as follows. So you have your epidural hematoma. Okay, so class, when I say epidural hematoma, recall that dura is the topmost layer of your meninges. So when I say epidura, that would be above the dura. Okay, that's why class is also referred to as an extradural hematoma. Okay, so class, it is shown in the picture. Now, class, this develops in the potential space between the dura and the skull. Remember, class, that your epidura and your and your subdural areas are just potential spaces. So, class, these are the diseases which would manifest or would increase the space between the two, or would occupy the space abnormally. Now, this is usually result from a torn artery. Okay, it may be also a result often due to skull fracture. Okay, so class, as you can see, there is a arterial blood here. And then class, we're talking about skull fracture which has compressed or injured your middle meningeal artery. Okay, so class, this rupture or laceration of the middle meningeal artery would result to bleeding. Okay, hence you have your epidural hematoma. Now, One thing that you need to note to the epidural hematoma is that it is unable to cross the suture lines. Now, clinical manifestation. There will be a momentary loss of consciousness. Your patient would have a lucid interval wherein he will be awake and conversant, few hours and then 1 to 2 days. Then later on, your patient would have rapid deterioration of the level of consciousness. Okay, why is the patient having the lucid interval? Because initially, okay, the hematoma might be able to control the hemorrhage that is occurring inside the patient's head. Okay, it may be that the supply of the blood leaking from the injured blood vessel is also covering for the succeeding amount of blood. But later on bleeding may continue. Hence, the patient may have rapid deterioration of the level of consciousness, which would be on the continuum being drowsy, confused, going towards coma. Then your patient would have seizure and then even headaches. Now, other than that okay, your patient may have hemiparesis. Depending on the gravity, okay, or depending on the extent of the compression of the nearby tissues, your patient may have ipsilateral or contralateral hemiparesis. When I say ipsilateral, that is on the same side. When I say contralateral, that will be on the opposite side. Okay, it may be ipsilateral, especially if the compression is just minimal. But it may be involving both ipsilateral and contralateral if the extent of the compression is already a lot. Then, your patient may have fixed dilated ipsilateral pupils, especially if I'm talking about the compression of your cranial nerve for oculomotor movement. Then there could be a rise in blood pressure with a decrease in pulse and respiration, indicating a rapidly increasing hematoma. Notice rise in blood pressure and decrease in pulse. Okay, you are recalling the signs of your Cushing's response and your Cushing's triad. Now, in subdural hematoma this would form between the dura mater and then the arachnoid. Okay, often this is venous in origin, although it may involve small arteries, but oftentimes these are veins. Now, so if again I would be differentiating between subdural and epidural hematoma, you can recall that your epidural hematoma would have a shape like this, okay, that of a pear, and then your subdural hematoma is comparable to a shape of a thin banana here. Okay, so this is because of the nature of the anatomy of your subdural space, wherein it is already surrounded by your dura mater above, and then your arachnoid space or your arachnoid sheath below. Okay, so for that reason, it tends to be elongated. Even though if the rupture is here, it has the tendency to spread here. And recall that this area is also rich for venous supply. Okay, so for that reason, it is spreading that way. Now, there are classifications of your subdural hematoma. An acute subdural hematoma, hematoma, would develop rapidly. The clinical manifestation may involve a unilateral headache, drowsiness, confusion, ipsilateral pupil dilation within minutes or hours of injury, and then there could be agitation, slow thinking, and even your hemiparesis. Now, your patient with subacute subdural hematoma are associated with less severe head injury. Okay, they may fail to regain consciousness following a close head injury, and the clinical manifestations would develop more slowly. Added to that, the next type is your chronic subdural hematoma. Your chronic subdural hematoma is often associated with relatively minor trauma, an example of which is fall. Now, weeks to months may elapse before manifestations of the hematoma would occur. Okay, that is related to the minor trauma that your patient is experiencing. This can occur spontaneously in the older adult or in clients with bleeding disorders. So even though chronic, if for example your patient had a decrease of their platelet or had a problem with their bleeding parameters okay, your patient may continue to bleed, okay, despite it being a chronic subdural hematoma. Now, your chronic subdural hematoma would be having the blood within the brain changes in character in 2 to 4 days. Okay, so recall we're dealing with hematoma. After 2 to 4 days, the hematoma there would be changing. Okay, after a few weeks the clot would break. This breaking of the clot would result to the calcification and ossification of the clot. Oftentimes, they would compare it to the color and consistency of the motor oil. And now, the brain will try to adapt to the foreign body invasion. Okay, while the brain is adapting to this foreign body invasion, which is your hematoma, which is calcified and ossified, okay, symptoms would be fluctuating. Okay, how can I say that there is calcification and ossification? Because if you would look at the CT scan image of a patient with subdural hematoma, notice that they are whitish. Okay, it's very white. Okay, it's already comparable to that of the bone. Okay? So class, that's why it can say calcification and ossification. Notice the color of the bone, class, when it comes to your CT scan image. Now, manifestations of this hematoma. Class, your patient would have, okay, the signs and symptoms of subdural hematoma may be mistaken as a sign of dementia in older adults. There will be slowed thinking. There will be confusion, drowsiness, lethargy, headache, dilation and sluggishness of the ipsilateral pupil. Then you have focal seizures. In other words, partial seizures may be experienced by your patient. And then personality changes, which could be neurotic or psychotic. Then the collaborative management for these patients are as follows. Accurate diagnosis and rapidly initiating appropriate interventions is necessary. And class, this is done. Okay, this is done with the use of your CT scan, MRI, and a thorough history taking for the patient. Okay, so class, if you are exploring a patient with a headache, exploring a patient with dizziness, other than thinking that your patient may be malingering, other than thinking that your patient may have hypertension, you should consider that your patient may have had, okay, your subdural or chronic subdural hematoma. So asking for the history of fall of the patient and the nature of fall, even if the fall was 6 months ago or a year ago, would still be vital for the history of the patient. Okay, as mentioned here, laboratory testing would be less value. Okay, class, the value of your laboratory testing would only come in if you are considering bleeding disorders. Okay, so for that reason, we will be able to help the patient and give prompt treatment. But other than that, class, it will be your imaging studies such as your CT scan and your MRI, okay, which will be able to help diagnose the patient. Now, so class, the treatment of choice for your epidural and large acute subacute subdural hematoma is no other than your surgical evacuation. When I say surgical evacuation, that would involve removal of a part there, okay, or removal of a hematoma there, class, okay, that is through the formation of your burr holes or making holes through your cranium and your craniotomy. Okay, class, you need to give supportive care for this patient. You also need to manage the increasing ICP and then prevent complications, especially that of immobility. Okay, so class, this is showing a left craniotomy and evacuation of subdural hematoma. Okay, so as you can notice, the hematoma was removed. So class, as you can see here, this is the removal of the skin flap. Okay, they're making the craniotomy. Okay, in other words, class, they're burning holes there. And then class, that part of the cranium would be removed, wherein an incision into the dura and flap would be created. Then as you can see, class, they're trying to evacuate. Okay, they are trying to suction and remove the subdural hematoma. Okay, then class, later on that would be replaced back, secured, and closed. Okay, that is if you're dealing with subdural hematoma. But if you're dealing with severe complications of brain injury, class, let's say, for example, there is swelling of the brain, okay, there might be a possibility that the cranium, that the part of the skull that's removed could not be returned already to the patient. Okay, so class, these are your basic steps for neuroendoscopic hematoma evacuation. Okay, also for your subdural hematoma. You might be wondering what's A, class. That's just a site marking. Okay, and then, yeah. Now, nursing diagnosis. Common to this patient will have your ineffective airway clearance. Why ineffective airway clearance? Okay, it's injury, class. Injury. Okay, so it may be secretions, it may be problems with the brain. Ineffective breathing pattern, especially if we're exploring again medulla oblongata problem. Altered cerebral tissue perfusion due to the compression of several parts of the brain. Sleep pattern disturbances, especially if your RAS is disrupted, and then class due also to the discomfort of the patient after the surgery. Okay, other than that, class, they would be feeling pain, headache, dizziness if they were not managed, so sleep pattern disturbances will still be there. Okay, so class, this is an immediate craniotomy and removal of brain tissue and blood clot. If you're really interested to know about this, okay, you'll have a hopefully you'll have your opportunity in the OR someday to see this. Okay, class, that will be all for your intracranial hemorrhage. We'll be proceeding to your disorders of cerebral blood flow, which is a very interesting topic. Okay, once again, level 3, I am thankful for your attention.